Hi everyone, and thank you for joining us, and a very warm welcome to our webinar on NDIS Community Physiotherapy. We'd love to hear your questions, so there's a Q&A function on Zoom, so please do ask your questions and we'll be happy to answer them as we go along. First, an introduction to our presenters. Myself, my name's Tom. I'm one of the principal clinicians at Better Rehab. I've worked here at Better Rehab for about 4 and a bit years now. And since graduating back in 2010, I've worked in almost every sector of the health system. That's acute inpatients, outpatients, and community. I entered the community disability space in 2018, and I've loved it so much that I've stayed here ever since. My role within Better Rehab is a clinical lead or principal clinician, and I use my knowledge and understanding of the health systems to help you learn and experience all community has to offer. And here's my colleague, Mary.
So my name's Mary. I studied a Bachelor of Physiotherapy at Western Sydney University, graduated in 2021. I started as a new grad here at Better Rehab, and I've been here since because I love it here. Love the community care so much, and wouldn't kind of want to move any other way at the moment. And yeah.
Perfect. Thanks, Mary. So as part of the learning outcomes of today, we're going to give you an overview of what Better Rehab is or who Better Rehab is. We're going to talk about our graduate program. We're going to give you a brief overview of the NDIS, and we're going to explore the role and scope of a community NDIS physiotherapist. And that doesn't necessarily need to be purely NDIS physiotherapist. It could just be a community physio as well. And to finish off, we're going to provide 2 real-life case studies. On the next slide is a video that gives you just a little bit of a flavor of what Better Rehab is all about.
What is better? It's been able to say you can to people who have always heard you can't. It's turning later into now. It's effort, it's commitment. It's overcoming challenges. It's creating opportunities. It's passion. It's support. It's togetherness. It's learning. It's growing. It's inspiring. It's questioning. It's leading. It's an input. It's an outcome. It's our promise. It's your reality. Better Rehab. Better for you.
Great. So that was Rachel, our director, and also a practicing OT. Better Rehab's Australia's fastest growing allied health provider of OT, SP, PT, EP, AHA, and PBS. We've changed the lives of almost 18,000 participants since 2017. And Better Rehab has an amazing stat of 60% of our senior leaders are women, which are most of them promoted internally. We boast that we've got an unrivaled work culture and team support. This can only tell you part of the story. Better Rehab was founded because we want to make a difference. Rachel, our director, who you just saw, is an OT and a university lecturer, and she hated the way services were being provided in the community to people living with disabilities. It seemed to Rachel that the whole healthcare ethos was to work slowly, not to give a damn about your clients, not to care, and rather turn up to work to get paid, rather truly in loving what you're doing. She found it incredibly frustrating and demoralizing, and this is how Better Rehab was born. That's really what Better Rehab is all about, is being better. It's helping more, it's making a bigger difference, and to be able to have done that for thousands of participants, ensuring we've got the best support in place for our clinicians to be able to go out and make a difference. And developing a culture that makes people want to get up and get going each day is the most amazing thing that we're trying to achieve. So Better Rehab is a values-driven company. And what I mean by that is our core values underpin the decisions that we as practitioners and operational staff make on a daily basis. As you can see from the values, we have 5, And I'll talk about the elephant in the room first, which is we get shit done. That normally gets people's attention pretty quick. But in all seriousness, our participants and colleagues rely on us. We don't waste time, and we work hard to help participants achieve their goals. We love what we do. We believe that when our people love what they're doing, the best outcomes are achieved. We employ people who are genuinely passionate about their profession, and we give a damn. Working at Better Rehab is a career, not a job. We are committed to providing you with the opportunity to make a difference to those who need it. And we are people. We are proud to be an organization free from politics and bureaucracy, and generally care about our interactions with one another and our clients. We take great pride in treating each client based on their individual needs, and that's also true for our staff as well. And finally, we value ourselves. We have confidence in our skills, training, and experience, and we recognize if and when we need support, we take care for ourselves and in order to take care for each other. So where are we located? As you can see, we're all the way through Australia, just Northern Territory to get next, but we're working on that one as well. So there's considerable opportunities right across the country. Our physio graduate program has been running for 3 years now, and it's just about to enter its 4th. It's a great program, and I can certainly speak from a New South Wales perspective, where we still have 2 of our original new graduates working for us today. So we must be doing something right. Each year we compile all the feedback from the previous year and use that to tailor the program. So our program has essentially been shaped by new grads, meaning that we really are confident that the program is relevant and accessible to new graduates. Our 2024 intake will be a year long, providing you with the time to get used to and get to know your varied and generalist caseload. We are firm believers that happy physios mean better outcomes, so we've really focused on a gradual ramp up of your caseload to give you space to reflect, clinically reason, and debate your participants with your peers and supervisors. As discussed, we have a strong MDT at Better Rehab, which pretty much covers the whole gamut of allied health, and they'll all be delighted to help you on your graduate journey. You'll have unlimited access to the Knowledge Hub, which is our own online university. This is where experts in subject matters such as pediatrics, respiratory, neuro rehab have all presented webinars, and these are anytime access. So you can do these on the road, you can do them at home, whenever suits you. We also like to have a good time, and we're always trying to get out and get socialized with each other, and we have lots of different events and parties throughout the year. So what is the NDIS? Well, the NDIS stands for the National Disability Insurance Scheme. The NDIS supports approximately 600,000 Australians living with a disability, allowing them to access the service and supports that they need. It provides funding to eligible people who live with a disability, namely to gain more time with family and friends, to gain greater independence, to access new skills, jobs, or volunteering in their community, and overall an improved quality of life. So what does the NDIS environment offer? Well, the NDIS is a community-based initiative. Community is great as it allows you to see the person in their own environment, providing you with invaluable insight into the demands of their day-to-day life. Hospitals and clinics tend to be level access and well-resourced, so give you a false picture of how well someone is coping. It's only when that participant gets home, often on their own, that their lack of independence really starts to show. Whilst we do operate fully stocked and resourced clinics, we spend over 80% of our time visiting people in their house, school, or chosen location. For those of you who've completed a placement in a hospital setting, you may notice that all the focus is on stabilizing the patient and then discharging them as soon as possible. I know this as I've worked in the inpatient system myself. Community physiotherapy allows you time with the participant and their support networks to actually work on what they want to work on, so that you're improving their quality of life. Sometimes the smallest tweak to someone's day-to-day routine can have the most dramatic impact. The NDIS attracts complex, generalist caseloads, which cover all permanent or significant disability. You're able to experience and learn many new things with no 2 days being the same. And with community life comes clinical autonomy. You're able to be more creative and innovative in the treatment plans you implement. Our supervisor team is experienced and flexible and will give you the tools and confidence to trial different evidence-based approaches rather than always following rigid guidelines. In the NDIS, you act as an advocate for your participant. through your assessments, intervention, and reports. The NDIS was developed to put the person back in the driving seat, so everything you do is to support the participant achieve what they want to achieve. And finally, the NDIS is growing and is projected to continue to grow. There are significant career opportunities and progression pathways internally and, of course, externally. So who actually uses the NDIS? When we interview new candidates, speak of new grads and lecturers at universities, the overwhelming kind of thought process is that it mainly consists of neuro, so strokes, and progressive neurological conditions such as MS or MND. These up-to-date figures show that actually autism, developmental, intellectual, and psychosocial disability make up the vast majority of the NDIS. This can come as quite a surprise to many clinicians, so it's good to discuss at this early stage. And happily for me, my background is in the complex psychosocial intellectual disability space, which is what first attracted me to the NDIS. So interestingly, at Better Rehab, we actually reverse those trends. You can still get your intellectual disability, psychosocial, and genetic caseload fix, but on average, we can offer a very varied true neurodisability caseload. We've achieved this through developing a well-supported multidisciplinary team who get the best results for their participants. Our principal clinician team have decades of combined experience in the disability and hospital sectors, so we're confident that we can support you to manage any situation that arises with any type of participant. These attributes make us highly sought after from referrers, recruits, and participants alike. So the benefit of being a Better Rehab physio is that you can sample all the NDIS has to offer and still get your fix of the plenty of progressive neuro. And here's a direct comparison with the figures from 2022. So now we have an overview of the basics of the NDIS and who uses it. But what about your actual role? So our main objective in the NDIS is to support our participants to reach their goals and improve their quality of life. The NDIS is a person-centered, goals-driven environment. Upon entering the NDIS, the participant will state what is most important to them to improve their quality of life, and we as practitioners respect those goals and tailor our approach to fit their unmet needs. The NDIS is not set up to treat a chronic condition, but to give the participant the functional tools they need to live with and thrive with their condition. Admittedly, it's a slight refocusing of mindset where you aren't always looking to improve a clinical outcome measure, such as a Berg balance score or a 6-minute walk test, but looking deeper into what effect reduced balance and endurance have on the participant and how that affects their ability to access the community and participate in activities of daily living and leisure. As with any physiotherapy intervention, movement and mobility are at the core of these processes. And may include education and prescription of assisted technology, something that's not taught in any real detail in the universities. In short, we need our patients to move, and in order to do that, we need to educate them on what movement is, what its benefits are, and how to move safely, whilst also encouraging the support networks around them to help assist. Finally, in order to build capacity and improve mobility, we are often in the position of equipment prescriber, and it's essential that the equipment we provide is suitable, safe, and effective to meet our participants' needs. So as we can see, the scope of a physio is broadly similar to that in the NDIS as you will be used to. From your placements that you've already been on, you've most likely worked in the hospital or clinical setting and would have typically seen the same type of participant all day, every day, until you rotate or even leave the department. Speaking from experience, this trend continues throughout your career until you make the change yourself. What's wonderful about community, and especially in the NDIS, you get to see the full breadth of the physio scope of practice and really use every aspect of your degree that we all studied so hard for. From this diagram, there's two areas that you may not have experienced in your university journey, and that's assistive technology and respiratory interventions, both of which I'll go through now. So assistive technology refers to prescribed equipment. The NDIS in general will fund a piece of equipment if it's directly related to a person's disability, if it will build their independence, is cost effective, and is reasonable and necessary. This can be something as small as an electric can opener, all the way through to the customized tilt-in-space powered wheelchair you see in this slide. Historically, occupational therapists are seen as the only discipline who could prescribe AT. However, I'm very pleased to say that physios are classed as AT assessors too. At Better Rehab, our experienced principal clinician team are experts at prescribing all manner of assistive technology, and we work closely with the occupational therapy team to provide an interdisciplinary team model rather than just an MDT. We're very proud of this fact. So if prescribing life-changing customized assistive technology is something that really gets you going, then the NDIS is absolutely for you. To ensure that we're always on the top of the game and on top of the latest assistive technology, we've partnered up with the top suppliers and manufacturers across Australia. With these partnerships, we as physios can provide the latest in cutting-edge assistive technology, as well as receive direct supplier to clinician upskilling. As an example, all of these partners provide Better Rehab with lunch and learn sessions, specific upskilling on products and hands-on training, such as how to do math assessments and how to set up a wheelchair or piece of AT correctly. On the next slide, we're going to go through some respiratory interventions. The volume might not be amazing on this, so I'm going to turn on the subtitles as well. Before we play the video, respiratory tends to be seen as a hospital-led domain. However, if a participant's respiratory presentation is directly linked to their disability, we can see them via NDIS funding. Given the correct training and with suitable participants, as a Better Rehab physiotherapist, you'll be able to work with respiratory consultancy teams to manage cough assist, CPAP, BiPAP, non-invasive ventilation, as well as learn deep suction, oral suction, and manual techniques such as vibrations and percussions.
My first name is Mark. I'm in a wheelchair because I've had motor neurone disease for about 17 years. My condition started only in my right leg and foot, and it remained in my right leg for about 6 years, I'd say. And so they didn't know what it was, because motor neurone disease doesn't normally present in that way. So mine was very atypical. It's also very unusual to have motor neurone disease for 17 years. Now it's had a major impact. I mean, I'm wheelchair bound. I'm having difficulty using my arms, having difficulty speaking. I'm the same person but trapped inside a body that's just not working properly. But that's okay. I mean, it's not devastating. I was a barrister for 26 years. I've only just stopped practice really because it's become so difficult in my wheelchair and with the limitations I have using my hands and arms, and obviously difficulties speaking. I've had a number of OTs and physios beforehand, and they weren't terribly proactive. Stephen's much more proactive.
So I started working with Mark in about May 2021 last year. When I first came on board, the initial approach we looked at was really in terms of joint management. So a key thing when it comes to motor neuron disease is obviously we start losing our muscle tone and we can't move our arms and legs as well anymore. We really found a key opportunity in looking at the respiratory care for him after doing some lung testing and identifying that he did have some significant difficulty breathing. After a short period of time, we realised that Mark was becoming more and more ventilator dependent. One key element that we're noticing was that his world was getting smaller and smaller. And when we first started, he was about 16 hours ventilator dependent, and it progressed to 18, 20, and we're very close to full-time dependent now. And his original ventilator device was not a portable unit, so effectively just needed to be plugged into a power point all day. And so what that meant was Mark was becoming more and more confined to his 4x3 bedroom and unable to go out for medical appointments, do the things that he loves out in the community, participate in the church, all that kind of stuff. And so after we had a look at some portable units, we ended up making some recommendations and helping him with the acquisition process, and that's really helped to expand his world now. So we've been able to provide him with the opportunity to get out of his house, go to his medical appointments, go to the zoo, which he's actually recently done in the last couple of weeks. And so, yeah, just the opportunity to be able to do and live the way that he wants to live. The impact that I can personally have on someone's life is truly profound in this role. And to be able to give someone the opportunity to live life the way that they want to live, that's not dependent on their disability, is something truly remarkable.
I suppose I've had so much help from Better Rehab that I really do want people to know how helpful they can be.
Great, so that was Mark and Steve there. So if respiratory care or respiratory intervention is something that really floats your boat, then our skilled principal clinician team have developed a thorough competency structure, which is directly mirrored off the acute inpatient setting. And we'll take you through that from start to finish. And that means that you've got the confidence and the ability to approach cases such as Mark's, to really develop your skill set and encounter everything that needs to be encountered in the NDIS setting. So I'll hand over to Mary now, who's going to run through one of her case studies. Take it away, Mary.
So currently I'm seeing a participant who's a 57-year-old female with primary progressive MS. Based on my assessment of the participant, as you can see on the screen, that was our problem list. She experienced reduced mobility, and I observed that she was using a walking stick and occasionally furniture cruising around her house, and she had a right hemiplegic gait, so had that strong right-sided weakness when walking. She had reduced endurance and MS-related fatigue. So I observed that, she was only able to mobilize about 2 meters before needing a standing rest break, or 12 meters before needing a sitting rest break. So quite limited in terms of around the house and in the community. She also experienced reduced functional balance, which was identified using the time up and go. She achieved a score of 37 seconds with a quad pod stick, and again with furniture cruising as well. So her physio goals were to maintain her mobility by being able to be independent around her house, and she was still happy to furniture cruise, but again, it's just being back to that being independent. And she also wanted to have appropriate AT to mobilize and access the community at least 100 meters independently. So how do we do that? I prescribed her some upper limb, lower limb range of motion exercises and strength exercises. I also prescribed her some balance exercises as well. I prescribed her a quad pod stick for indoor use, so she felt more safe around the house. And then a 2-wheel pickup frame, so she can use in her backyard, as she really loved to garden. I provided education regarding fatigue management, self-pacing, heat sensitivity, and how that can impact her fatigue, as well as the importance of appropriate exercise environment. Currently, we're in the process of completing an application for a power assist wheelchair for community access. So what is a power assist wheelchair? It's pretty much a manual wheelchair that you might see in the hospital or even on, in the community. It has a power attachment to it, which allows the participant to propel forward while reducing the wear and tear of their shoulders. As Uni has drilled into our brains, working as an MDT is very important and allows us to provide the best care. So myself and the OT completed a joint trial for the power assist wheelchair, and together we'll be able to successfully find a suitable AT for the client that her and her husband were both happy with. Things that we had to consider and account for was, the wheelchair features and how customizable it was, as MS is progressive, so it's more likely that the current wheelchair that she has will need more support in the future. Seating for comfort, as well as pressure injuries, which, the OT might have some expertise on, as well as her husband, as he is the main person that's going to pack in this wheelchair in and out of the car. So he had a history of frozen shoulder, tennis elbow, and back pain. So we wanted to reduce manual handling and care burden as much as possible. Another incident where we worked as an MDT was I see the client quite regularly for therapy. So I was able to identify her having difficulty and safety issues with car transfers. And I had a discussion with the OT. The OT was able to come out to review it. And now the OT is currently organising an electric step for the client to ensure safe car transfers. So yeah.
Thanks, Mary.
Yeah.
Wonderful. A nice complex case there, and something that is quite impressive to be approaching just 18 months into your career. So done.
Well, look, at Better Rehab, we get a lot of support, not only from clinical supervisors, but Tom has really helped me. We've discussed this case a few times and gone through the clinical reasoning about the power assist wheelchair and the longevity of it as well. So yeah.
Great. Wonderful. So, as you can see, the world of community disability is a really exciting and it's absolutely enormous, and that can be quite daunting, which we fully acknowledge and appreciate, and so do the APA. And so in order to meet the demand for quality upskilling in the community space and to get more physios into this community space, the APA have entrusted us at Better Rehab to create the brand new learning pathway of Disability Level 1. So this would be similar to your Neuro Levels 1s, your PEDS Levels 1s, and we're really excited to be providing this upskilling. And this isn't just for new graduates, it's for experienced clinicians who want to start to move into the community setting. And it provides a real nice, good base for you to start with the idea that as things progress, we can start doing Disability Level 2, where we can start to talk about more complex interventions. But as part of Disability Level 1, it is going to have the basics of assistive technology prescription and also the respiratory things that you've seen today. So in summary, the role of the NDIS community physio is to build function, not to treat diagnosis. Your scope of practice is huge and it's very varied. You can use every aspect of your degree in the community. And Better Rehab PTC comparatively higher neuroprogressive neuro caseloads compared to NDIS norms. The principal clinician team and supervisors will provide you with the support you need to flourish as a new graduate or inexperienced NDIS clinician. And I've just gone through, the APA have entrusted us to provide this service to the whole of Australia. So it's very exciting. Thank you very much, guys.
All right, thank you, Tom. Thank you, Mary. There have been a few questions that have come through. So I'll kick off with one for you, Mary, if you don't mind first. Someone would like to know what a typical day looks like for you at the level that you're at within Better Rehab currently.
So currently, in terms of my day, first thing in the morning, I usually check my emails, I check my Teams. I might see 2 clients in the morning, then I go back to the clinic, write some clinical notes, have lunch with my colleagues, might chat with them regarding cases or, small MDT updates regarding clients, then might do a few exercise programs or reports, and then see 1 client on my way home. So pretty good, not too overwhelming. And then, if I work extra hard during the week, then I get to leave early on a Friday when I've hit my weekly target, or I can choose to stay and get some bonus points. So yeah.
Love the decision of a knock off early or some bonus points. It's a nice night. What you want to do on a Friday. Wonderful. Thanks, Mary. I might flick this on to you as well. What made you, as a graduate, choose Better Rehab over any of the other opportunities that you had at that time?
I think coming out of uni, the main thing I wanted to look for was support, because I did really, I was able to compare, my placements where I had a lot of good, strong support versus ones that I didn't, and how I felt as a clinician. And so support was one of the biggest things, as well as team dynamics. And I guess with Better Rehab, looking at the graduate program, knowing that I had a set amount of hours each week for clinical support, but not only that, that was for clinical support, and I still had a team leader, my work colleagues to support me as well. And then working in that close MDT space, I think, yeah, really made the big difference, knowing that there will be clients that I have the OT current in the same clinic, really, and we can just kind of chat very quickly rather than having to open my laptop, write an email, them not replying. But yeah, so I think support is a huge thing that made me choose Better Rehab, and definitely they've been the best.
Good to hear. Excellent. Another question for you as well. How did you find the report writing aspects of working within NDIS? Do you find it daunting, and do you find that it takes a lot of time? Great question.
In all honesty, at first it was quite, I guess, confronting, because again, uni doesn't really teach us how to write a report properly. And so it was scary, but after one or two reports, going through it with my clinical supervisor during our supervision, getting the feedback that we get, it becomes less daunting. Actually becomes quite nice here and there, having days where I could just do a report day, work from home, or like report day and bring the dog into the clinic. And it's really nice having a report to separate some therapy time. And then, when those AT reports come through, again, it's that support we have at Better Rehab. There's, we get it QA before it gets sent anywhere. So yeah, not as daunting as it is, but it's a good challenge. Yeah.
Brilliant. Thank you for that. Tom, this might be one for you, or Mary, feel free to answer again. What are the weekly targets and KPIs that you have to meet as a clinician?
So we do 4-week cycles, which is basically made up of 4 weeks, and the end target is 100 hours of billable work per cycle. So if you purely strip that back down to a weekly thing, it's 25. But we appreciate that some weeks are busy and some weeks are quieter. So there's ups and downs, but ultimately we have 100 billable hours per cycle. If you choose to do any more, wonderful, you'll be rewarded for that with some bonus points. But if you'd like to stop at your 100 and go home and just have, as Mary mentioned, kick back, relax on a Friday, that's absolutely fine as well.
Fantastic. And if anyone would like more information about those benefits, we're happy to, if you want to reach out afterwards in regards to the rewards, benefit and the flexibility. So a bit more info we can give you about those as well. But thank you, Tom. A question I can probably answer actually. Which Better Rehab locations have 2024 physio graduate positions available? All of them was the answer in terms of states. Within each state, depending on the number of offices and the scope for each office, there might be different numbers of graduate headcount that we would be looking to take on next year. In some areas we are at capacity, however, we may potentially increase the number of opportunities towards the end of the year. So at this point, we'd encourage any of you to apply. If you're interested, let us know what location you're in, and then we'll be able to talk to you about the specific office and what vacancies we've got for next year. So, and each year, no doubt, we'll be building on the numbers as well with our programs. So wonderful. A question that's come through. I read about Better Flex program on the website, as we were just mentioning. Could you explain more on it? Can I choose when I want to schedule clients and write notes or reports? Tom or Mary, would you like to explain?
I can probably explain it, then Mary can maybe give an example of it. So Better Flex is an amazing opportunity to have a very flexible work environment, and it's very, very popular with our mums and dads who choose to work at different times and different hours. From a business perspective, once you've kind of got your feet under the table and you can prove that you're absolutely fine and capable with your caseload, then yes, you can take days here and there, or half days, or move things around and finish a bit early or start a bit later. And that's basically open communication with your direct supervisor and yourself. We need to know where you are. We need to know what you're doing or what your plans are. And ultimately that revolves around keeping your diary up to date. And with regards to that, we just want to make sure that our participants don't suffer. So we do make sure, or try to make sure, that you guys are available, contactable during the day, in the mid part of the day as well.
Yeah, so I guess with the Better Flex, I've used it on two different types of ways. One where I had a trip booked Friday afternoon, so I knew I had to finish early by Friday lunchtime. And so that just meant I did it about maybe 45 minutes extra each day on Monday to Thursday. And then again, I didn't have to call. I did the full-time hours. Another time I did better flex is again hitting that target. So there are cycles where, you know, I've hit that target by Thursday, and then you can take the whole Friday off on the last Friday of the cycle, and that's been really nice as well, because you can book any appointments, you know, self-care, whatever you want to do, go out with your friends, and yeah, early weekend pretty much. So it's really nice.
And for parents, it could be that you need to start the day a little bit later to do the school drop-off, work during the day, do the school pickup, and then do some work later on when the kids are asleep. And that's absolutely fine. And certainly on my team, I have at least 4, off the top of my head, at least 4 of them are mums, and they provide the main caregiving role as well. And so the Better Flex works great for them.
Fantastic. Thank you both very much. Couple more coming in thick and fast. Do we offer part-time? I can answer this one. Yes, we do. As a graduate, if you're on the graduate program, it is full-time hours. So we do look for full-time hours during that graduate year. However, for any experienced clinicians or moving beyond the graduate role, we're happy to consider part-time hours. So normally 3 days a week or 4 days a week is ideal in terms of keeping up a caseload. But we've discussed that with you in terms of what you're looking for, and can be fairly flexible in terms of days that you work. So yeah, absolutely. Next question. What is the greatest distance you will travel to see clients? Does Better Rehab provide compensation or access to a company vehicle? Great question. Tom?
I can take that. Yep. So 30 minutes is the greatest distance from either your home or your office, depending on the situation, and that discussion can happen with your direct supervisor. Look, on occasion, you might get caught in traffic and have an extra 5 minutes, but we try to keep everyone within that half an hour zone. There are very, very, very rare occasions when you're going rural or remote, but again, those are very few and far between. And as compensation, we do the ATO per kilometers method. There's no company cars or anything like that, so you'll be directly reimbursed for what you travel. And I believe, off the top of my head, it's 92 cents per kilometer, and that's for this year, this financial year.
Fantastic. Thanks, Tom. Another question, are there a certain amount of billable hours given for report writing? And if so, how many?
Yeah, so reports, basically, the report is very, very important to making sure that your participant has the right support that they need in order to get the funding that they require. So what we do is, as Mary said, you'll go through the reports with your direct supervisor. It will also go through a quality assurance process where it comes to myself and the other principal clinicians. One of our values is that you value yourself. So you value your time and you bill in real time. So if a report takes you an hour and a half, you bill an hour and a half. If a report takes 2 hours, you bill 2 hours. If it's an extremely complicated case that requires a lot of research, a lot of development, a lot of bits and moving pieces, and it could take 3 hours, you can bill for 3 hours. So we want you to value the time and effort you put into your reports. And there's always assistance around you to make sure that you're not just staring into space and looking at a jumble of letters on the screen. We can help you be efficient with your time so that you can pass on a very efficient and effective report to your participants, but also making sure that you're not shortchanging yourself as a therapist.
Thank you. Next question is, what is the adult pediatric caseload split for a graduate physio?
So depending on what your definition of pediatrics is, so the NDIS is 7 and up, so 7 to 65. So pediatrics tends to cover from, well, in an NDIS perspective, it's 7 to 16. However, Better Rehab is an early childhood approach approved provider, and there's opportunities to treat participants from the age of 1 or even younger and up. From a graduate perspective, we want you to get used to and comfortable with the 7 and up age range first, before then you can then interview for the ECA scheme, where you will be, if successful, you will be exposed to the younger generations. But that there is, again, want to make sure that you get your feet under the table first and you're happy and you're able to do your job well before taking on quite intense patients or participants below the age of 7. And from a participant split, again, you could have anything any day from a 7 to 65 percentage. I don't have the age ranges off the top of my head, but there's quite a lot of teenagers on the NDIS, and there's a lot of kind of 20s to 40s as well. So it's kind of a mixed bag, and it depends on where you are and what the demographics are in your area. If you're in an older retiree area, then you're going to get older caseload. If you're in a younger, maybe in a city environment, you're most likely going to get younger participants. It's a bit of a mixed bag.
Thanks, Tom. Another question, I'm not sure if we'll be able to answer this, but someone's asking, can we quickly run through what an NDIS report would look like or involve?
I can tell you what it involves, but running through it would probably take quite a while. So an NDIS report would give a bit of background history on the participant. So that would be like their past medical history and social setup. You then talk through the goals, the NDIS goals that were agreed by the participant and the NDIS, and you would show your physiotherapy goals underneath. And then you would talk about how your goals meet the NDIS goals. So, for example, a goal could be for an NDIS participant to get back down to the cinema. Well, which is just down the road, 1 kilometre down the road. Well, from your physio assessments, you've worked out that actually it's their cardiovascular endurance that is limiting them from getting to the cinema 1 kilometre down the road. So therefore, your physio goal will be to improve their 6-minute walk test, for example, over the course of this plan in order for them to get down to the cinema. At the end of the plan, you'll then go, well, this is what we agreed at the start. This is how it went. Have we achieved the goal, yes or no? And if it's a yes, wonderful. If it's a no, why not? And what barriers were there to your intervention? And then you do an evidence section detailing what or how to back up what you're asking for next time. So say you hadn't achieved that goal, you'd only got 500 meters out of 1 kilometer, and that's the participant's one goal. Your evidence will be, well, for this person who has COPD or stroke or some sort of condition that reduces, let's say fatigue for Mary's example, we need to give evidence of what MS is, how it affects fatigue and endurance, and the positive effects of physiotherapy intervention and what we're expecting from our intervention. So it does cover quite a lot, but it's all clinical, and it's all very, very, new graduates tend to be very good at it because you're all used to writing your dissertations and evidence-based practice. So it's something that we will work with you to help you, and we'll also make sure that you're fully supported the whole way through, because we've got to make sure as a business that we're looking after the participants as well to uphold our reputation. So we'll fully support you from start to finish.
Yeah. Thank you. And a great question that's come through: how could grad physios, or I guess any of our clinicians, receive support to mitigate complex or dangerous situations during home visits?
Wonderful. So that's a great question. So I've been in the community now since 2018, and there is always risk. There's always risk. There's risk crossing the road. There's risk getting into a car. There's risk getting onto a bus. So Better Rehab has a risk assessment, which is a compulsory document, which means that you must speak to the participant or the participant's referrer or the participant's carer if the participant can't speak, and run through a very thorough screening of any behaviours, any concerns, any issues, anything that you're not sure about. We offer, in certain cases, you can go with a buddy, you can take a panic alarm, and essentially we make sure that if there's any doubt about anything, you are supported. And it could be that the patient comes to the clinic, it could be that you meet in a public area. There's a million different scenarios that I can think of, which all have a slightly different approach. But what I can say is that Better Rehab implements the same risk assessment process as the public health system, and that's the same in New Zealand where I've worked, in the UK where I've worked, and also in Australia. So we copy everything they do and make it our own and give a little twist, but we follow the same processes that everywhere else does as well.
Brilliant. I think that might be it for questions. Some really excellent questions that have come through, and lots of them, which is wonderful to see. I'll just give a final shout out for any other questions before we finish up. No, wonderful. I think that's it from the Q&A section. Brilliant. All right, wonderful. Anything else you wanted to add, Tom or Mary, before we finish?
Thanks very much for attending, and well, hope to speak to you all soon.
Yeah, thank you guys.
Wonderful. Thanks everybody. Enjoy your evenings.